colleague Dr. Chandrasekhar has spoken about her, and she has tremendous work on celiac disease. And she will be talking to us on celiac disease. And we now realize celiac disease is important. Certain region of India has celiac disease quite prevalent, going to about 1 to 2% among the school children. So it is an emerging disease, is a major cause of malabsorption in India as well, not only in the West. So Professor Amin, please go ahead. Thank you.
Perfect. Thank you for that kind introduction, and good evening, everyone. It's still morning here in Rochester, Minnesota. We're still drinking our first coffees of the morning. So I just want to thank Dr. Chandrasekhar. Hopefully you can give me a thumbs up if you can hear me okay, see me okay, and you can see my screen okay. I see a nod. Perfect. 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 Well, thank you for the kind invite. It's amazing to be here on behalf of not only Mayo Clinic, but American College of Gastroenterology, who, is happy to endorse such an amazing webinar series, amazing speakers that you have set up for the rest of this year. So my charge over the next 30 minutes is to talk about celiac disease and malabsorption, and really focusing more on celiac disease, which is clearly, the quintessential stereotype for a malabsorption syndrome, talking about what's new and what's upcoming in terms of the future of celiac disease. So I have nothing to disclose related to this topic. So really at the end of these 30 minutes, these are the things that I hope you will walk away with. And I know there are many questions that the audience members have, and I've seen some of those questions, and I know that if I don't get to them during the session, we will talk about them later in the discussion as well in the panel. So I want to be able to describe the pathogenesis of celiac disease and have you understand that. I want you to be able to leave this talk detailing the factors that may increase the risk for celiac disease. I want you to be able to recall the testing used to screen and then ultimately diagnose celiac disease, and list the management strategies for those who have diagnosed celiac disease. So again, just on a very high level, we have to remember, how do we make a diagnosis of celiac disease? Oftentimes there may be something of clinical concern, a laboratory abnormality, a clinical feature, but many of our patients may be completely asymptomatic, only detected through family screening or other measures. We like to see supportive and positive serology, and we have highly sensitive, highly specific serology that we'll talk about. We like to see stereotypic small bowel biopsy findings to diagnose celiac disease, and then we should see a clinical response once a patient is put on a gluten-free diet. Now, the really important thing is, before you put someone through this workup of diagnosing or evaluating for celiac disease, remember that the serology and the histology is highly variable on the intake of gluten-containing diet in those patients you're wanting to rule out celiac disease, realizing the serology can normalize very quickly in the order of weeks to months, and biopsy findings can normalize in the matter of months as well. So again, to be certain about the diagnosis, make sure that the patient's on a gluten-containing diet if possible. So why is this topic of relevance? Well, you already heard in the introduction the very high numbers that you're seeing, and we see this worldwide. This is a common entity. When we look at the US population, it's approximately 1%. So, I tell my colleagues that if they, for every 100 patients they're seeing in, let's say, a general GI practice, if they haven't made the diagnosis, they're probably not thinking about it often enough. And why is that the case? Why has this been underdiagnosed in the past? Well, we know there are a lot of non-classical features. So we have to raise awareness of those features, because people need to know when to think about celiac disease, when to screen for it. We also know there are more patients being labeled with celiac disease, but not all of them meet the criteria. You're going to hear in the next lecture about non-celiac gluten sensitivity, but there are others who are labeled prematurely with celiac disease before they've had an appropriate workup. And me personally, I feel like we should be as certain as we can with the tools that we are equipped with to make this diagnosis, because subjecting someone to a gluten-free diet, short of any of the novel therapies that could be coming down the line, is really a life-altering, prescription you're giving to that patient. And so I think it's really important to be sure about that as much as possible. So the pathogenesis of celiac disease is really quite fascinating. I'll just go through it quickly here, but remember, you really need three things, and I'll highlight this in a minute as well. You need genetic propensity, meaning you carry one of the permissive celiac genes. you need to be taking in gluten in your diet. And then there are some other environmental factors. And this is a huge basket of unknowns. We know what some of those may be, but there are many we don't know. So really what happens is that at-risk patient, meaning at risk because they carry the genetic susceptibility, they ingest gluten, and those gliadin get through increased intestinal permeability for whatever reason has caused that. Gliadin is then deaminated. You can see then the antigen presenting cells, again, those with the permissive factors of HLA, DQ2 or DQ8, present that gliadin to the T cells. You can see the T cells then recruit other immune cells. You can see those T cells release a lot of cytokines that further damage the small bowel and see the histologic findings that celiac disease is known for. You can see that tissue transglutaminase acts on those residual pieces of gliadin, connecting them here and making them even more antigenic. And so what you see then is a humoral immune system producing antibodies, again, and those are the tools that we use to screen for disease. I know some people have asked about dermatitis herpetiformis, so I added a few slides here just to show what is the relationship between celiac disease and dermatitis herpetiformis. So again, I've just gone through the physiology that we see with celiac disease. Again, the tissue transglutaminase antibody creating those tissue transglutaminase antibodies that we know of. Well, those antibodies can cross-react to epidermal transglutaminase, and you can see when that happens, there's a neutrophilic response. That's the inflammatory response we see in the skin from that cross-reaction, which gives us the typical skin findings that we see in patients with dermatitis herpetiformis, which is a neutrophilia affiliated skin condition. So this may be an extreme case of what this looks like, but dermatitis herpetiformis, remember, this represents the intestinal sensitivity to gluten. We often have patients ask, is this because my skin rubbed on counters that contain gluten-containing products? No, this is really because of that oral ingestion of gluten-containing products. What distinguishes this rash is it's very itchy. You can see even though it's called herpetiformis because they look like herpes vesicles, often patients will come to you and these are completely excoriated, scabbed over because they're so pruritic. Oftentimes on extensive surfaces, and the skin biopsy can be pathognomonic. Now, most of these patients will have no GI symptoms, which is pretty challenging because while you can provide dapsone and other topical agents to help control the skin manifestations and the skin itching, that doesn't heal up the process that is triggering this, which is gluten in the bowel. So again, these patients need the same sort of treatment that those with celiac disease need, which is a gluten-free diet, which we'll go over more in a bit. So here are some of the clinical questions that I think I'm asked the most about when seeing patients with celiac disease. First of all, who's at risk? How are antibody studies used in the diagnosis? Is HLA testing of any value? What is the bowel histology seen, and what are other things that can cause similar findings? And then finally, how do I manage celiac disease, including those patients who are non-responsive to a gluten-free diet? So I already mentioned who's at risk. Again, they have to carry permissive celiac genes. They have to be taking in gluten. And then there are either additional environmental or genetic factors. And again, we know some of them. There's been discussion about how wheat is processed, the age of wheat intake, the route of delivery at birth, the timing of gluten ingestion in childhood, infections, which may alter gut permeability and other alterations to gut microbiome. I think it'll be interesting, and we've already seen and what we'll see in the years to come as a result of COVID infection. I've had a number of patients diagnosed with celiac disease in the weeks to months after active COVID infection. So the global prevalence of celiac disease, and again, this is from a systematic review and meta-analysis from 6 years ago now, and we probably will continue to see changing trends. If you take serology worldwide and looking at almost 300,000 patients, it's about 1.4% based on serology, slightly shy of 1% based on biopsy findings, with about half the number of patients included. And we see geographic variation. And again, these numbers can vary. So you can see anywhere from 0.4 to 0.8, upwards of other areas that are over the 1% and can vary by age as well. We also know based on some US studies that there is a correlation with your degree at northern latitude. So the more northern latitude you are, the higher your odds ratio of celiac disease. So there's a lot of variables, all of which we don't know and we can't control for, and obviously things that we may not be able to prevent for as well. What we know from NHANES data, this was up to a decade ago, and again, we need to continue to trend this data going forward, is that the percent of patients with diagnosed celiac disease is fairly stable when you look at the overall disease. What you can see is the number of those with undiagnosed celiac disease is going down, meaning we're getting better at thinking about this entity and evaluating for it. So again, if you look at the overall prevalence of celiac disease, again, shy of 1% when you look at all comers. When you look among those who are of white race, again, higher at 1%. And this is some of the challenge that we will face. And again, you'll hear about this in the next lecture. There are approximately about the same number of patients with diagnosed celiac disease compared to those who are on a gluten-free diet but have not been diagnosed with celiac disease and choose to be on that diet for a variety of reasons, either because they have been erroneously diagnosed with celiac disease, but more importantly, they've chosen to be on it for symptom management. So again, that's important to think about. And I think that actually has helped our patients with celiac disease, to be honest, to make more availability of foods that are gluten-free. So when should you start to think about celiac disease in your clinic? Well, I think very commonly. So you think about the difference between adults and children. We often think about diarrhea, again, a classic malabsorption syndrome, and that makes up approximately a third of the patients who have celiac disease. You can see iron deficiency anemia is the next most common non-GI manifestation of it. Early osteoporosis, osteomalacia can be a feature of it, family screening. But then there's this huge wedge that is other 20%, so pretty common. Those could be abnormal liver biochemistries, either primarily because of the celiac disease itself, or it could be other autoimmune conditions that are often associated with celiac disease, like autoimmune hepatitis or primary biliary cholangitis. In this 20% might be infertility, a peripheral neuropathy, other neurologic manifestations, really multi-system sort of findings, which is very different than the pie you see here for children, where growth issues is a huge piece of the pie, family screening because of a parent or relative with celiac disease, abdominal pain, very common. Again, you can see diarrhea is actually much smaller compared to those in the adult population. I think the other really important thing to think about is, in the past, we would often dismiss a patient with a high BMI or body mass index that, oh, they can't have celiac disease because they're overweight or obese. But 1/3 of patients with celiac disease are obese or have a high BMI at the time of diagnosis. So again, make sure you don't exclude those patients in your mind and work them up just like you would any other. And some of those patients are obviously at risk of worsening and elevating their BMI on a gluten-free diet, because a gluten-free diet does not always equate to a healthy diet, right? They still need to eat a balanced diet. So how do we use antibody studies in the diagnosis of celiac disease? So, these are really the commercially available serology today. The old gliadin antibodies, which really have fallen out of favor, low sensitivity and specificity. We no longer use those. Endomysial antibody are still widely available. Again, you can see great test characteristics. This test is typically more expensive and more subjective compared to tissue transglutaminase antibody. And you can see the IgA TTG, very high sensitivity, high specificity. It's objective, less expensive than the endomysial antibody. And then finally, you have the deaminated gliadin peptide, which is the new gliadin peptide. So when labs read out a gliadin antibody, oftentimes it's the deaminated gliadin. Currently, no longer is this even used. You can see the IgA version has okay test characteristics. The IgG variety has very good sensitivity and specificity. So it's better than the traditional gliadin, but really probably equivalent to TTG. And this is one to use in IgA deficient patients. The really important thing, again, to know is that the IgA TTG is the endorsed screening test of choice. So that's the one you should use if you're looking to screen for celiac disease. The guidelines would say we should avoid checking panels, meaning sometimes people are tempted to order all of these thinking the more you check, the more likely you'll find a positive result. And that's true. You're more likely to find a positive result, which may be a false positive. The other thing to note, and I'll mention and show this in a slide, the higher the level of the TTG, the greater the likelihood ratio that that patient actually does have celiac disease. So that leads to the question, does everyone need a biopsy to make a diagnosis of celiac disease? Well, we know based on, our pediatric guidelines for kids, this has been the non-biopsy approach has been an approach that's been supported for some length of time in symptomatic children who have a TTG greater than 10 times the upper limit of normal, and they also have a positive endomysial antibody. And you can see in the study for kids, the TTG antibody upper limit of normal, when you look at that level of 10, much more likely from, here MARSH 0, MARSH 1 or 2, much more likely to have significant enteropathy. Well, what about for adults? Again, we'll talk about the patients that should have endoscopy, and I would endorse that for really almost all adult patients. They should have upper endoscopy, but I know that's not always possible because of endoscopy availability, anesthesia support. I have patients who are pregnant who choose not to have an endoscopy at that time, which is absolutely reasonable. So for select individuals, again, like I mentioned, there's a positive predictive value that's very high, the higher the TTG is. So again, you look for those who have a TTG 10 times the upper limit of normal, the positive predictive value is nearly 99%. So again, in those patients, I think it's very reasonable if they can't undergo an EGD or it's not available, if they have a very high TTG greater than 10 times, very likely they have celiac disease. So then some people will say, well, what's the role of ever checking their HLA status? Is this of value? And I think it is in a select number of patients. I don't check this on everyone by any means, but I do check it in a few select patients. So remember, patients should carry either the HLA DQ2 most commonly or DQ8 permissive gene to be at risk for celiac disease. Now, the thing that's tricky is 30 to 40% of the population carries one of these permissive genes, yet we don't see that percent of patients with celiac disease. So we know that this is necessary for celiac disease, but in itself is not sufficient to give you that condition. What it is useful of is the negative predictive value, or NPV, is nearly 100%. So if I see a patient and they don't carry either of the two permissive genes, I can tell them quite confidently they don't have celiac disease. So who might I use this in? I might use it in someone who has discrepant serology and histology, meaning serology is positive, but their histology is unremarkable and their biopsy numbers have been adequate, and I'll go over that. Or the histology shows a classic enteropathy, but their serology is unremarkable. I will check it or consider checking it in those who are already on a gluten-free diet but now want to undergo testing and a gluten challenge. So again, that could be useful if they don't have a permissive gene. I don't need to put them through a gluten challenge. And then there's a question of whether we should use this for at-risk individuals. It's probably not as helpful for family screening because in families with celiac disease, there's a higher likelihood they carry one of the permissive genes if they have a family member with celiac disease. But you could think about this in certain at-risk individuals, such as those with Down syndrome or some of those with other conditions that have a higher affiliation with celiac disease, because again, if they don't carry a permissive gene, you don't need to screen them regularly for celiac disease. So what is the bowel histology that we typically see? And again, it comes back to who should we biopsy? So the guidelines still suggest that all adults who have a positive serology should undergo small bowel biopsies to evaluate, and strong features even if their serology is negative. So if you have a patient with diarrhea, iron deficiency anemia, and their serology is negative, again, that might be a patient who probably needs an upper endoscopy or endoscopic evaluation anyway. Very reasonable to check small bowel biopsies because our serologies are not perfect, as you saw. Why do we do this if you have a high TTG or a positive TTG? Well, it allows confirmation of the diagnosis. And for me, it's also very helpful to get a baseline before a gluten-free diet is introduced. Because when I see that patient in follow-up and when I re-endoscope them 2 years later, hopefully their small bowel biopsy is normal at that time. But if not, I can compare the number of intraepithelial lymphocytes, the degree of villus atrophy compared to when they were still consuming gluten. And again, most cases of celiac disease are going to involve the proximal duodenum, so small bowel biopsies in the duodenum are of high yield in those cases. Now, people will say, how many biopsies should I take to make a diagnosis of celiac disease? So I think in the past, 4 used to be the number that we would all think about. But as you can see here, the percent with celiac disease that's diagnosed, it's proportional to the number of biopsies taken. So in this case, more is better. And I think 6 is considered the sweet spot. 4 from the post-bulbar duodenum and 2 from the duodenal bulb would be the marker and the goal. What I would say is that number is important because if you are seeing a patient who is scoped elsewhere, I always say look at the endoscopy report. Oh, there's someone coming through the speaker here. So always read the endoscopy and pathology report on outside biopsies where there's a question about the diagnosis, because maybe only 2 biopsies were taken and that's why the yield was low. So again, I would say always make sure that there's an adequate number of biopsies, especially if everything else looks compatible with celiac disease, but the biopsies were negative. Like I mentioned, where do you biopsy? So again, based on some data, we know that you should, take at least 4 post-bulbar biopsies, but taking several from the duodenal bulb is also recommended. Now, again, most people will just take 2 biopsies randomly from the location in the duodenum. But if you're going to take the position with the highest yield, think about the 9 and 12 o'clock positions, because in these positions, when the patient is in the left lateral position, those are the ones that are where gluten has the most contact with the patient who's eating upright. So why do we take bulb biopsies? In the past, I think we always used to say that duodenitis may be mistaken for celiac disease. I think our pathologists have, an astute eye for detecting the difference, and it does increase the yield for celiac disease by on average 10%, and it covers villus atrophy in 14% of those with celiac disease who might still be getting some gluten contamination, and we can only notice that in the bulb. There are patients who have, involvement of the bulb only. Those patients tend to be younger, as you can imagine, have lower antibody levels and oftentimes less clinical symptoms. This is another question that, very proficient and efficient endoscopists want to know. Can you take more than 1 biopsy with each pass into the duodenum? Does that change or affect the yield? And the study here showed the percent of well-oriented specimens, really in all patients, those with known or suspected celiac disease, those with villus atrophy, and a final diagnosis of celiac disease. And you can see in all cases, when there was 1 biopsy taken with each pass of the biopsy forceps, the yield was much higher than people who took multiple biopsy or double biopsy with each pass of the biopsy forceps. We also know that in the past, some people would say, well, gosh, the duodenum looks normal. I don't need to take biopsies. But we know the sensitivity of any of those endoscopic findings, loss of folds, nodularity, is very, very low. Now, if you look, the specificity is actually very high. Now, this isn't specificity for celiac disease, although that's going to be the majority of these patients. That's high specificity for an enteropathy of some sort. So that just behooves us, if you see a patient endoscopically with loss of folds, scalloping, nodularity, take small bowel biopsies while you're there, because you're likely to find something. So what are those findings that we typically see? Again, we see typically villus atrophy. We see, total, here's normal, partial villus atrophy, total. And remember that intraepithelial lymphocytes, that's the minimal histologic finding. So if you don't see that, it really should make you question the diagnosis. What are other things that would be unusual? Well, if you see mucosal erosions or ulcerations, that would be unusual for celiac disease. Now, it could be ulcerative jejunitis, but again, that would be unusual for typical celiac disease. Neutrophilia in the infiltrate. Let's say you have an enteropathy, but there's no intraepithelial lymphocytes, or the lymphocytes are not on the tips that are typically seen in location in celiac disease. That's unusual. And then things like loss of goblet cells, loss of plasma cells, cryptapsices, deposition of excess collagen, or if you do specific staining and look for loss of CD8. Again, those should be a warning sign that something else is going on. Well, what about those patients that only have intraepithelial lymphocytes on their small bowel biopsies? So we know that that's common. And the study that we did, looking from the year 2000 to 2010, you can see that this went from about 3% of all duodenal biopsies that we did at Mayo Clinic over that 10-year period, over 10% in 10 years time. So again, this was based on almost 16,000 biopsies. And when we took out those patients with known celiac disease, less than 10% of those patients had celiac disease. This finding was often attributed to something else, ibuprofen, other NSAIDs, H. pylori. So again, it really should make you pause to make a diagnosis of celiac disease based on that histology alone, especially if there's unremarkable serology. Because remember, everything that causes intraepithelial lymphocytes is not celiac disease. I already mentioned some of those here. Everything that causes villus atrophy is also not celiac disease. Again, it's going to likely be the most common, but think about things like combined variable immunodeficiency, autoimmune enteropathy, sprue, Whipple's disease. But probably what we see most common on this list nowadays are medications. And so probably many people have heard, and again, I don't know where you're all practicing or where you may have these medications available, but we did see, olmesartan as a cause of um, angiotensin receptor blocker induced enteropathy. And this came out of patients who were diagnosed with, quote, celiac disease who didn't respond to a gluten-free diet. These patients may be on this medications for many years before they come to clinical attention. What's interesting is their likelihood of carrying one of the permissive genes is double the general population. So there likely is some molecular mimicry, but most of these patients almost exclusively have clinical remission with drug discontinuation alone. Other medications to think about that we see commonly in practice: checkpoint inhibitors, mycophenolate mofetil, as well as others. So remember, this is what a patient with celiac disease biopsy would look like: villus atrophy, crypt hyperplasia, lots of chronic inflammation in the lamina propria, lots of lymphocytes here on the intraepithelial border. In a patient with olmesartan, it can look identical. You may see a little bit more collagen deposition, maybe a little bit more of neutrophilia, but otherwise they're often indistinguishable. Compare then celiac disease, again, that same image, with someone with combined variable immunodeficiency. Look at how their lamina propria looks empty because they're missing the plasma cells in the lamina propria that you would typically see with celiac disease. How does autoimmune enteropathy compare histologically to someone with celiac disease? Here you can see in the crypts, you can see the goblet cells. Here you can see this patient must have anti-goblet cell antibodies. There's just a paucity of goblet cells here in the crypts. And then finally, celiac sprue. It might be hard to see on a low-powered view, but high-powered, you can see a very thick collagen band that's just engulfing all of these lymphocytes here, which would be abnormal. So how do I manage a patient with celiac disease, including those who are non-responsive? So when you see a patient at the time of diagnosis, you're assessing their symptoms, you're checking their serology, you're getting the biopsy. I typically check basic nutrient levels. I will have them see a skilled dietitian to talk about a gluten-free diet. I will check their bone density at baseline and then recommend family screening for all first-degree relatives. I typically will have them come back at 4 to 6 months, again, assess their symptoms if they had any, recheck their serology to make sure it's downtrending, and then any other labs that were abnormal at the time of diagnosis, like nutrient levels, I will recheck. Typically then I will check their serology annually. Typically we'll check a follow-up small ball biopsy set at 2 years' time to give them enough time to heal. I will only repeat a bone densitometry if the first one was abnormal. We have to remember, then, it comes back to that first slide of why all of this is so important, because patients, this really impacts the patient's quality of life. In fact, when you look at all of the chronic diseases, end-stage renal disease is the only one that has a higher visual analog scale score compared to those patients with celiac disease. So it has significant impact on their quality of life. You can see their satisfaction with a gluten-free diet. More than 40% is poor or very poor in terms of their satisfaction, understandably. And then you look at this pie chart, you can see that 80% of patients have a great deal, quite a bit, or moderate desire to wanting a medication compared to a gluten-free diet. And I find this, it's real. If you see these patients, that's what they ask you. But it's such an interesting paradox, because we have patients with inflammatory bowel disease who will say, can you give me a diet rather than a medication? And these patients, we have a diet, but they want a medication. So again, you have to realize this is very life-changing for everything they eat. It's just, we take it for granted, everything we put in our mouth, we don't have to think about it, but these patients do. There are patients that are at higher risk of either contamination or compliance issues. So if they're diagnosed at an older age, and I've diagnosed patients in their 70s, and they may say, I've gone my whole life eating what I want, it's very hard to change behavior. Those who are in their teenage years, college, kind of those transformative years, it's very hard to be different. And so that can be challenging. Those who travel a lot, go out to dinners a lot, that can be hard because you don't have control of what your food intake may be unless you plan ahead. Those who are detected through family screening, who are often asymptomatic, again, very challenging sometimes to get them to buy in. There are lots of compliance scales. Honestly, this is the simple one that I use. I just ask patients to tell me on a 0 to 100 scale, do they have total disregard for what goes in their mouth, or are they 100% compliant, meaning be as strict as they can be? And I try to normalize this as part of the conversation, not put any guilt on them. Just say, give me a number, 0 to 100. And if they tell me anything less than 100, again, that gives me a great teaching opportunity to show them why it's important to get to 100%. We know that there are patients who have non-responsiveness, either primary non-responsiveness, meaning they don't respond initially to the gluten-free diet, or they initially respond, but then later have recurrence of symptoms. And that's 15% of all patients have non-responsive celiac disease. You can see gluten exposure, either inadvertent or knowingly, is the biggest culprit. So it's always important to assess for that, assess their medications, which may be compounded in wheat-containing factories. Remember, irritable bowel syndrome can coexist with celiac disease, so think about that. And then think of all the other things we might see commonly associated. Microscopic colitis, again, very common. Disaccharidase deficiency, often lactose. Again, it makes sense. It affects the duodenum where this disease occurs. Don't forget about eating disorders, bacterial overgrowth. And then people always worry about refractory sprue, which is understandable, but again, that makes a small piece of this pie. So what do I do in those cases? The first important thing is to make sure that original diagnosis was correct. Look at the original slides of the biopsies. What were their serology? If things are discordant, again, look at their HLA. How did they respond to a gluten-free diet? And maybe they never had celiac disease. Maybe they had one of these things we talked about. Let's say they've been compliant with the diet. And so, if you're not sure, do a careful dietary review. If their serology is elevated, almost surely they're getting some gluten in their diet. And that's where you want to re-educate with a dietitian, a medication review, and do close follow-up. Once you've gone through those things, then you have to think about those initial or additional diagnoses. Maybe they have microscopic colitis and you need to get colonic biopsies. Maybe they have bacterial overgrowth. Maybe they have something else in their small bowel like IBD that you need to assess for. Do they have carbohydrate malabsorption? So those are things to think about. And just remember, more than two diseases may coexist. So that's always important to think about. Well, I mentioned refractory celiac disease. Remember, this is where you have enteropathy and persistent features despite compliance with a gluten-free diet for 12 months. So in type 1, there's no clonality to those lymphocytes. In type 2, there is clonality, and usually have a loss of CD8 staining, and that portends a higher risk of lymphoma and a poor prognosis in those patients. So again, this would be normal, kind of equivalent or equal CD3, CD8 staining. This would be abnormal when you see that discrepancy. So what do we often use currently for patients with refractory celiac disease? So we'll often use open capsule budesonide, 9 milligrams total a day. The first one, we will have them open the capsule and take the beads inside and chew or masticate those with some soft food. Middle of the day, I'll have them do an open capsule and swallow those intact granules without chewing them and take the entire capsule in their evening meal. And you can see that in patients with both refractory type 1 and refractory type 2, large number with both clinical and histologic response. And in fact, half of those with type 2 refractory celiac disease had absence of clonality at follow-up, which is pretty amazing because in the past we used to think that those patients had no great options. There's also some studies showing some use of budesonide for non-responsive celiac disease, but I would say that really has to be after you've done a thorough evaluation for other causes of why they have refractory symptoms before you expose them unnecessarily to budesonide. Lots of current and emerging therapies. And again, this could be a talk in and of itself, whether it's peptidase. I mean, you can see all of the numbered therapies here, but peptidase therapies, those that block permeability like lorazepam. You can see anti-IL-15 treatments. And then gluten tolerization. And obviously there's been the attempt at vaccination, but there's I think this is where we're going to see the future of this disease in terms of, stem cell therapy. Now we're seeing cellular, molecular, bispecific therapies where we're likely going to be able to train these patients' lymphocytes to respond in a different way. And again, this is a great review from Nature Review of GI and Hepatology. You can look up all of these medications and see all of the where those studies are at. So in the last minute here, is there a role for following gluten detection in body fluids? I would say no. The guidelines would say they're not real time enough. You can find gluten in the stool or urine for days after ingestion. Is there a role for gluten detection devices? No. Again, too many false positives and too many false negatives. And finally, people often ask if there's a role for probiotics. And there's really no benefit yet established. So if someone's on them and they feel well on them, fine. But again, I usually never start someone on them based on the guidelines. So in summary, non-classic monosymptomatic features of celiac disease are common ways this disease still presents in adults, but it's essential to get adequate histology given the yield on small bowel biopsies correlates with the number of biopsies taken. Remember, if a patient with a diagnosis of celiac disease is not responding to a diet, first establish if the diagnosis is correct. Fourth, remember the most common cause of non-responsive celiac disease is gluten consumption or cross-contamination. And then finally, in the patient with refractory sprue, open capsule budesonide can be used for clinical and histologic improvement. So I want to thank you for your time and attention. Look forward to the discussion that ensues.
Thank you, Amy. It was a great presentation. In a short time, you covered every aspect of celiac disease, starting from pathophysiology diagnosis to refractory celiac and the potential thing which are going to come in the future. So I think we'll go to the next session now. Am I right, Dr. Chandrasekhar?
Yeah, and
Okay.
now I'll introduce the speakers first. I must thank now Professor Amy Accentingo for the wonderful lecture and excellent discussion of the what is celiac disease and the various the features of celiac disease and how to diagnose what is refractory is true and other thing. Now we'll move on to the next lecture, and it's my pleasant duty to introduce the next speaker. Next speaker is Professor Dr. Govind Makaria. He is a professor and head Department of Gastroenterology, All India Institute of Medical Sciences, New Delhi. He is the Honorary National President of Indian Society of Gastroenterology. He is a member of the National Advisory Board, Indian Journal of Gastroenterology. He's got a special interest celiac disease, inflammatory bowel disease, and functional GI diseases. He has got publications over 580 with a H index of 60. Now it's my pleasant duty to introduce the speaker to Professor Malati. Is a senior consultant gastroenterologist, MGM Healthcare. Is a professor, HOD retired, Department of Pediatric Gastroenterology, Institute of Child Health, ECMO, Chennai. She's got an outstanding achievement award by the Tamil Nadu Dr. MGR Medical University. She has got a publication over 80 in the field of pediatric gastroenterology. Now, let me invite Professor Malati to introduce the topic and to carry on with the further proceedings. Thank you. Can you unmute Dr. Malati? Please unmute. Dr. Malati?
Can you hear now?
Yeah, we can hear you.
Yeah. Good evening. It was indeed a very excellent lecture given by Dr. Amy. And now I would like to invite Professor Govind Makari. It is my privilege to invite him. He's the president of ISG, and recently he conducted one excellent international conference on celiac. So after I attended that, I realized how little I know, and I actually don't know. And it was very nice, 2.5 days on celiac disease, and then he had this session also. I think this is his real favorite topics. Now he's going to talk about non-celiac gluten sensitivity. Yes, it is a controversial topic, but I know for Dr. Govind everything is very easy, and he will give us an excellent lecture on that. Thank you, Dr. Govind, for coming, and we're just waiting to listen to you.
Thank you so much. Thank you so much, everyone. Thank you, Dr. Chandrasekhar, for your kind invite Thank you, Dr. Malati, for a kind introduction. And we had a wonderful lecture by Dr. Amy all about celiac disease discussed today. I hope I'm audible to everyone.
Govind, everything is clear.
Perfect.
Your audio, video, everything clear.
Perfect. So as Dr. Malti said, that the term non-celiac gluten or wheat sensitivity is a term which is either myth or reality. I thought I'll start with that only, that is a myth or reality, non-celiac gluten sensitivity or non-celiac wheat sensitivity. The first thing that for non-celiac gluten sensitivity, there's no known biomarker, and therefore this term remains in question. There are two kind of people. The group of people believes that there's such a disease, which is called non-celiac gluten sensitivity. At the same time, they are non-believers. But the truth is, there are proportional patients or people who gets better in terms of GI symptom when they stop wheat. So I'll discuss this entity into 5 or 6 subheadings, that what it is, how common is the non-celiac gluten sensitivity, how do we suspect, how do we diagnose, how do we treat, and how do we follow these patients. Coming to what it is. We all know that food induced diseases are very common, either food induced symptoms or food induced diseases. And I discussed this in 4 contexts. The most important context is that food-related disorders are obesity, cardiovascular, fatty liver disease, and also some congenital syndromes, which are food intolerance. The first context. The second context, when the food-induced symptom happen, is that if you ask anybody in the world, almost 25% of people will say that they have some kind of food intolerance. After taking food, there are some form of GI symptoms. And this study from the US, when they asked normal people, almost 1/4 people said that after taking some food, they have symptoms of GI disturbances. The third context, which is that in those patients who have IBS, and we asked them, almost everyone says that their symptom of IBS gets worse with certain kind of food. This is all well known. Now the fourth context is adverse reactions to food, which are 2 kinds. Either they could be immunologic or they could be non-immunologic. In the immunological disorders, either could be IgE mediated or non-IgE mediated, or mix of both IgE mediated and non-IgE mediated. In the second group, in non-immunologic, they are host dependent and host independent. In host dependent, there are multiple toxins or pharmacological agents. In host dependent, lack of enzymes like lactose, some food irritative, and some are undefined. Look at immunological food disorders like food allergy. Many people will have an allergy to seafood, egg, peanuts, wheat, and milk. Right? Similarly, for those who have enzyme deficiency, they can have milk intolerance. At the same time, number of people are intolerant to high FODMAP diet, also to wheat. So with this context, we come back to a case scenario. This is a person who is a 36-year-old person who came with chronic diarrhea for the last 6 months. Diarrhea was intermittent but moderate in volume. He had mild anemia, no pain abdomen, and no intestinal obstructive features. He complained of fatigue, and for this, he went to doctors. And what was found on investigation, that he has mild anemia. The other cell counts were normal, like normal white cell counts or platelet counts, normal renal functions, normal liver functions. His serology for celiac was negative. The normal serum immunoglobulin levels. The negative serology for endomysial antibody. Stool test was non-contributory, and he underwent a duodenal biopsy, which shows mild increase in intraepithelial lymphocytes, while the Crick-Willis ratio was normal. For these symptoms, he was given a symptomatic treatment, but symptoms persisted. So his drug was checked. He was taking any kind of drug which can reduce symptoms, but no such drug was found. So there were no forthcoming diagnosis. So he was given 4 weeks of antibiotic for his GI symptoms, and also given antiparasitic drugs. But despite their symptoms persisted. And meanwhile, he also developed headache, confusion, and irritability. So he went to other physician, and he was asked empirically to stop gluten from the diet and advise a gluten-free diet. To that, his symptoms got better. The first to go was headache and confusion, and over weeks, his diarrhea also got better. So at this point in time, he started, once symptom got better, he was started on gluten-containing diet, normal diet, but his symptom worsened. With this kind of scenario, he came to us and asked, what should I do? How long do I go for gluten-free diet? So this is the context. So this is a patient who came with GI symptoms, had response to gluten-free diet, and on stop the gluten-free diet, he became symptomatic again. So meaning thereby, there are few individuals who have GI symptoms. The symptoms respond with gluten or wheat withdrawal. And in these patients, there's no adaptive immune response. I mean, there's no serology is negative, and also there's no enteropathy. These are called non-celiac gluten sensitivity or non-celiac wheat sensitivity. So looking at gluten-related disorder, as discussed by Dr. Amy, that there are three kinds of disorders. Number one, they're autoimmune. They could be allergic, and they could be non-autoimmune, non-allergic. So in autoimmune, we have classical type celiac disease, for which we have a discussion by Dr. Amy. We have a dermatitis herpetiformis, which responds to gluten-free diet. And one more term is now coming up, is the gluten ataxia. There are certain people who have a ataxia, and the cause is gluten in them. The second group is allergic and typical wheat allergy. But in these patients, there will be more of skin manifestations. They can also have GI manifestations, but after taking wheat, they will have a skin manifestations. They can have anaphylaxis. And the third group, which is non-autoimmune, non-allergic, and these are non-celiac sensitivity or non-celiac wheat sensitivity. Now, I like to use this term interchangeably during my talk. So it has been seen that there's an overlap between those patients who come with GI symptom, and in those we diagnose functional GI disorders, either dyspepsia or irritable bowel syndrome. At the same group, we have a group of patients who have gluten-related disorders, namely celiac disease, non-celiac sensitivity, TH, wheat allergy, and gluten ataxia. There's a lot of overlap between these because most patients who have a non-celiac gluten sensitivity, they have a symptom like IBS, a typical like IBS. And even those who have celiac disease, they can also have symptoms like IBS. So there's a lot of overlap in between the symptoms of irritable bowel syndrome and gluten-related disorders. Therefore, if the patient comes to us with a pain, discomfort in abdomen, diarrhea, or constipation, or abdominal discomfort, we often diagnose them as a functional GI disorder, either dyspepsia or IBS. But in this subgroup of patient, a small number may be celiac disease or non-celiac gluten sensitivity. So how common it is? So as I said, that there are a group of people who have a symptoms on ingestion of gluten or wheat, and symptom gets better once they stop gluten or wheat. So this disorder, how common is there in the population? So this is a study from Italy, where Italian young adults were asked about how many of them have symptoms which are gluten-induced and how often they are. And what they've observed, that self-reported gluten-induced symptoms were almost 487, about 6.4%, had a self-reported non-celiac gluten sensitivity. But if they've asked about, once look at medically diagnosed non-celiac, were about 1/4 of them. And the most frequent symptom were bloating, pain abdomen, and tiredness, meaning thereby about 6% of people, young people, say that they have a wheat-induced symptoms. Coming to other study, the study again from Italy, that those patients who were referred for endoscopy, 20% agreed that the symptoms get worse once they take wheat. Study from India, from Mumbai, Dr. Philip Abraham's group, that they investigated 204 subjects with IBS, And they found that 11.3% reported that they have a worse IBS symptom on ingestion of wheat. And none in 400 healthy people. It's surprising, but 11% of patients who have IBS has gluten-induced or wheat-induced symptoms. And once the wheat was stopped in them, all got better. Furthermore, study from Korea, 1/3 of patients reported they have wheat-induced symptoms. So of all of these, it looks like some of them may be because of many other regions, but some of them have a true non-celiac gluten sensitivity. Look at other studies, one study from the US, two studies from the US, and one from Italian. But again, there are no study from population. They are all hospital-based studies. And in all three studies, about 0.6 to 6% of people who report into hospital with GI symptoms were diagnosed to have a non-celiac gluten sensitivity. Therefore, while celiac is 1% of global population, non-celiac is much more common, maybe up to 5%, at least 5% of a population have wheat-induced symptoms. It's much more common than celiac disease. So we talked about what it is and how common is a non-celiac gluten sensitivity. As I said, at least 5% of global population will have this disorder. Then how do I diagnose? If the patient comes to us, when do I suspect and what do I diagnose? So as I said, that there's no criteria at this point of time, but a lot of people, especially in US, Europe, and Australia, when those people have a GI symptom, and there's a trend that you go gluten-free. If you go gluten-free, the symptoms gets better, and they diagnose themselves as a non-celiac gluten sensitivity. And with that diagnosis, they come to physician and ask for opinion that do I have a non-celiac gluten sensitivity? So when do we suspect? So we suspect on clinical symptomatology. As I said, most patients with a non-celiac gluten sensitivity will have a symptoms which mimic like functional GI disorders, either dyspepsia or functional GI disorder or IBS. The most common symptoms are bloating sensations. They can have abdominal pain. They can have lack of well-being. They can have tiredness. They can have diarrhea, irritable bowel habit, abscess, myalgias. And one of the symptoms which a lot of people come, that foggy mind, they forget, their forgetfulness is one of the important symptoms of this disorder. They can have anxiety disorder, they can have headache, and uncommon, they can have anemia, they can have ataxia, they can have depression, and also mood swings. So these are the common symptoms when we suspect non-celiac gluten sensitivity. All of them are non-specific, none is classical, but again, all of these symptoms overlap with many other disorders. So this point of time, somebody come with these symptoms, there's no criteria based on that we suspect that this is a non-celiac gluten sensitivity. The question patient come with these symptoms, but the real question is, how do I diagnose that this patient has non-celiac gluten sensitivity or non-celiac wheat sensitivity? So how to diagnose? There's a criteria which is worldwide accepted, that if you have somebody coming with either GI or extra GI symptoms, as I described earlier, if you suspect, you like to rule out celiac disease by doing a serology, and there's a negative serology to celiac disease, and this suggests there's no adaptive immune response. Serology means what? There's a T cell response. T cell lead to stimulation of B cells. B cells form antibodies. So no B cells means no T cells, therefore negative serology. There's no enteropathy, or there's only mild enteropathy. But if you stop wheat in them, the symptom gets better. And if you restart them on gluten, the symptom gets better. So symptom gets worse. So again, if you remember 20, 25 years back or 30 years back, we used to diagnose celiac disease like this. Once we didn't have a biomarker, say 25 years back, all celiac were diagnosed based on the 3 biopsies, that you have a normal diet, you have a symptoms, you stop wheat, the symptom gets better, and you demonstrate healing of mucosa, and you give a challenge of wheat, and again symptoms get worse. At the same time, the biopsy becomes worse. means enteropathy become worse. And advent of serology led to simplification of diagnosis. It means you can diagnose celiac disease without going through this rigorous phase. But for same is applies for non-celiac. At this point in time, we don't have serology, we don't have biomarker. Therefore, we have to follow this clinical algorithm that patient have symptoms, you stop wheat, symptom gets better, and once you start wheat again, symptom gets worse. And the hallmark, which is advised, that just not because of just only on gluten, but keep gluten challenge in a double-blind form. So what do you do in that? Once you suspect non-celiac gluten sensitivity, give on gluten-containing diet for 6 weeks if they have symptoms. So step one, ask them to go gluten-free, and for 6 weeks. They are gluten-free for 6 weeks, and you observe them every week on a questionnaire and look for response in symptoms. If they improve, if they don't improve, if they don't improve, you can exclude non-celiac gluten sensitivity. But if they improve, then this point of time, you come to step two. That step two, continue gluten-free diet, but at the same time, either A or B. A is again gluten and B is a placebo. So again, give either A or B. We give small amount of gluten, 6 gram gluten, or B is placebo, and look at response. If symptom worsen or if they don't worsen, again, give gluten-free diet for 1 more week, and again give reverse. If you're given gluten earlier, then give placebo and look at worsening. By this double-blind placebo-controlled trial, you will able to confirm that his symptom worsens once you give them gluten, and symptoms don't worsen once you give them placebo. And this is how we diagnose a non-celiac gluten sensitivity. But again, this is very tiresome. This is a long process, and there are also some restrictions to this diagnosis. I'll come back to that in a minute time. So those patients who respond to gluten-free diet, the question comes, they responded to what? Once you stop wheat had multiple components. Wheat has a gluten, which is inside, which is the protein of wheat. It also has FODMAP, and it also has a ATIs. ATIs is amylase trypsin inhibitor, which is very important, which don't allow this protein to be degraded. And ATIs are part and parcel of wheat grain. So wheat will have a 3 component: the wheat protein, they will have starch, but again, all these layers will be FODMAP, and also will have ATIs. So if you stop wheat, patient gets better. But how do you know the patient got better because of stop of the gluten, FODMAP, or ATIs? And how these symptoms appear? So again, as I said, wheat has a protein and carbohydrate. This is how they lead to symptom. Proteins, as I said, there's the ATIs, the gliadin, and other proteins, and these proteins lead to by different ways, and they stimulate innate immune response and lead to GI symptoms. The symptom can also happen because of carbohydrate, because of this carbohydrate, which is a non-digestible fructans. They will be acted upon by bacteria, or that leads to, in the large intestine, lead to more gas formation and GI symptoms. So therefore, the symptoms in these patients can occur because of wheat carbohydrate or wheat protein, and we are not really sure that what really happens. And also at the same time, ATIs, and ATIs are very, very important targets in leading to symptoms of non-celiac gluten sensitivity. So how do we distinguish the patient getting better because of stoppage of gluten or because of stoppage of FODMAPs? And this still remains a research question. There are a lot of studies on this aspect, but again, till now, we don't have clear-cut answer. So therefore, people use the term non-celiac gluten sensitivity, or a lot of people prefer to use the term non-celiac wheat sensitivity. As I said, the patient respond to either FODMAP or gluten, and there are multiple studies which is still not clear that the symptom respond because of gluten or FODMAP. Studies are in favor of both, but at this point in time, we don't have consensus. Now, a question may come that the patient responded to FODMAP or gluten. Can we know it? Could there be a biomarker? And which can help us understand that the symptoms or this entity is because of immune response or because of gluten. And many of you remember that the first antibody detected for diagnosis of celiac disease was anti-gliadin antibody. But because of false positive report of anti-gliadin antibody in patients with celiac disease, this antibody is no more used in the diagnosis of celiac disease. But there's a recent interest in this antibody in context of non-celiac gluten sensitivity. So can this antibody help that this patient has a non-celiac gluten sensitivity? And there are data from Italy to suggest that those patients who are diagnosed to have a non-celiac gluten sensitivity, 50% of them, at least half of them, had IgA class of anti-gliadin antibody. So anti-gliadin antibody, could that be a biomarker to really predict if this patient has a non-celiac gluten or wheat sensitivity? And therefore, we designed a study to think that if AGA could be a biomarker for non-celiac gluten sensitivity. Here, one of my colleagues, Anam Ahmed, did the study involving 500 patients with 513 patients with IBS. And of that, we could recruit 492 patients, and they underwent both serology for anti-TTG antibody for celiac disease, and also anti-gliadin antibody, both IgA and Ig subtype, in these 492 subjects with IBS who were diagnosed based on Rome 4 criteria. And what we observed that about 429 were negative for all antibodies, 2 were positive for anti-TTG antibody, and they were diagnosed of celiac disease. One, they have enteropathy, and 61 had only AG antibody and negative anti-TTG antibody. Means 12%, 12.4% patient with IBS of these number had AGA antibody and TTG negative in them. So we thought this could be a potential patient who can have a non-celiac gluten sensitivity. And of these patients, we invited them to participate in a gluten-free diet trial. Of them, 31 agreed. And in 31 patients, we give 6 weeks of gluten-free diet. And every week they were asked questions about are they responding to or not. And what we found that 4 patients did not have improvement, any improvement in their GI symptoms, and they were called non-responders. And how we look at it, we ask the patient to put all the GI symptoms into an order and ask 3 base symptoms which gets better. In 17 patients, there were improvement in 30% symptoms, which is a criteria for response as per the Salerno criteria. If somebody responds in 30% in top 3 symptoms, they call improvement. 17 had improvement, and almost not many patients had improvement in by 22%, what we call partial responder. So looking at this criteria, what we observed that at least 17 patients had confirmed non-celiac gluten. We have given re-challenge after they respond. We gave them gluten, and all 17 had worsening symptoms. Therefore, we could say that these 17% has a confirmed non-celiac gluten sensitivity. So using AGA could be an important biomarker. But more importantly, what happens to this AGA titer once you stop gluten? And what we found, those patients who had response, the titer of IgA and IgG titer of anti-gliadin antibody came down on gluten-free diet, suggesting that anti-gliadin antibody could be a biological marker for diagnosis and also for biological marker for response. Again, this is to be validated in many more centers and larger clinical trials. So what we understood that 12.4% of patients with IBS have some form of gluten sensitivity, and AGA could be a biomarker. Half of these patients do respond to gluten-free diet. The second question is that as it is said that non-celiac gluten sensitivity do not have enteropathy, and therefore the biopsy in them is normal. But again, this is not true. This is a study which of multi-country studies of 9 centers, including our center. In those patients who have 175 patients who were diagnosed to have a non-celiac gluten sensitivity by clinical criteria, and along that, the biopsy was compared with controls and celiac disease, and it was found that indeed these patients of non-celiac has a villus height which is less than controls, and so the crypt depth is less than controls, more than controls, and the cleft villus ratio is less than controls, meaning thereby patients with non-celiac gluten sensitivity have mild enteropathy. They are not normal. Even the IL counts are higher compared to controls. In addition to anti-glycan antibodies, there are many more biomarkers being investigated, but none of them are at this point of time for clinical value. The question still remains that how do I diagnose if patient comes with GI symptoms or extra GI symptoms that this patient had non-celiac or non-celiac wheat sensitivity. So as I said, at present, since the pathophysiology is not very clear why it happens, the lack of biomarker, therefore, the diagnosed celiac disease is based upon a clinical criteria. So what is the criteria? The criteria is suggested symptom, as I said, both GI and non-GI symptoms. What is GI? Bloating sensation, pain abdomen, diarrhea, change in bowel habit, foggy mind, confusion, discomfort, and anxiety disorders. So there are symptoms, the broad symptoms. Then these symptoms gets worse on consumption of gluten-containing diet. And as they take gluten-containing diet, the symptom worsens within hours and days. There's no evidence of celiac disease and wheat allergy. And most important, the symptom gets better on stoppage of wheat or gluten. So this is a criteria at this point in time which is used world over for confirmation of this diagnosis. And also the ideal way to confirmation. So the symptom gets better, but again, you're not sure that why symptom getting better. So always give a re-challenge. So re-challenge of gluten is the hallmark for diagnosis of non-celiac gluten sensitivity. Not only stoppage, but again on re-challenge, the symptom reappears is the diagnosis. And for that, the prescribed method is double-blind trial, as I described earlier. But again, double-blind trial is not easy to do. And why it's not easy to do? That even patient have a worsened symptom with gluten consumption. Rather than getting improvement, they also symptom get worse. And also patient gets symptomatic with placebo. So again, this criteria of double-blind control trial is still not very clear. So what do I do? So suggested criteria that if you have these symptoms on gluten-containing diet, you can use your predictability of patient having non-celiac by using anti-glycan antibody, either IgG or IgA. If you can do that, give them gluten-free diet for 2 to 4 weeks. If no improvement, exclude. There's no non-celiac gluten sensitivity. If they improve, you could provisionally diagnose as a non-celiac. Give them a gluten challenge at a later date, and if symptom worsen, then you confirm a diagnosis of non-celiac gluten sensitivity. Coming to the two last part, that how do we treat? Again, as I said, the treatment, once you suspect non-celiac gluten sensitivity based on clinical criteria, stop gluten and wheat and look for patient response. And this is the only treatment known at this point of time. Unlike celiac disease, as Dr. Emmy said, there are many more targets to attract to, or many targets to look at to. But at this point in time in non-celiac gluten sensitivity, the only treatment is stop the gluten and wheat. How do we follow? Again, there's no criteria at this point of time. Like celiac disease. Celiac disease follow-up criteria are now getting more and more established. But in non-celiac gluten sensitivity, there's no defined criteria that how long to follow. And now there are studies to show that gluten sensitivity in many patients is temporary. So their symptom get better on gluten stoppage, but when they start gluten again, there are no GI symptoms. So still, it's not very clear who are the patient to follow and how long to follow. So another point I want to make out here, that is not only in these patients, not only non-selective sensitivity, but some of these patients with IBS, which we're talking in the context I'm talking about, also have celiac disease. So how many patients with IBS may have celiac disease? And this is a systematic review to suggest that of all IBS patients, about 3.3%, so 1 in 30 IBS, so every 1 in 30 IBS patients, or in 100 IBS patients, 3 have celiac disease. 3 in 100 have celiac disease. Which type of IBS? We know 3 types of IBS: IBS-C, IBS-D, and IBS-M is all there in all 3, but more often seen in IBS diarrhea-predominant IBS and IBS mixed type. Is less common in IBS-C, but again, otherwise, is in all patients with IBS, there is a non-selective sensitivity. Therefore, all patients with IBS-D and IBS-M, we must investigate for celiac disease. So therefore, all patients with IBS must screen for celiac disease, especially those who have IBS-D and IBS-M. And not only IBS, but there's a study from our center that not only IBS, but also they have a non-selective sensitivity if you use AGA. In patient with IBS, about 30% had AGA antibody in another study, and of all dyspepsia, about 19% had anti-gliadin antibody positive. Again, this is a study we conducted this year, and we concluded this year. This is a study from Asian countries, and once we looked at in patients with IBS, how many patients have celiac disease, and we found that 2.4% of all IBS patients have celiac disease in Asia. To conclude, non-celiac sensitivity or non-celiac wheat sensitivity is a real entity. It's not a myth. About 5% of global population may have non-celiac gluten sensitivity or non-celiac wheat sensitivity. About 10% of patients whom we diagnose IBS may have a non-celiac gluten sensitivity. And this is a real opportunity that these patients who have long-standing symptoms, they can get better if you diagnose them non-celiac gluten sensitivity. Once we suspect, there's no biomarker, and diagnosis is based upon clinical grounds, and response and relapse with withdrawal with rechallenge. Anti-gliadin antibody could be a biomarker to predict some of the patients with IBS in whom we can predict this patient could have non-celiac sensitivity for gluten-free trial. With that, I'll stop and take any question.
Yes, thank you, Dr. Professor Govind Makaria, for that excellent exposition on non-celiac wheat sensitivity. I think you have made all of us believers in CTS with your way of presentation. It's really excellent, and I think we will go to the next session. Thank you so much.
Thank you, Dr. Malati and Dr. Govind. I initially started as a non-believer. Then after listening to a lecture, I started believing. Particularly the double-blind placebo-controlled trial was very interesting. I think we'll have more deliberations once both the lectures are open. Thank you, Dr. Malati. Stay with us, all of you, and both moderators, Dr. Malati and Dr. Uday Ghoshal, all the panelists and ambassadors. Now the session starts now. The first question is from Dr. Uday to Professor Amy Aksentenko. Dr. Uday, set the ball rolling now. Dr. Uday, you can come into the audio video.
Yeah. So, Dr. It was a very great presentation. But what I'm saying is there are some studies that show that patients with IBS-D particularly have positive fructose hydrogen breath test suggesting that they are malabsorbing fructose, which is a high FODMAP food. So, what is your comment on that?
So I do agree. I do agree that FODMAP story still stays. We need to go further. That once you stop wheat, so the wheat stoppage lead to improvement symptom. We cannot be sure that they are improving because we are thinking only two terms, FODMAP and gluten, but also ATI is very important because if you look at about less than 0.5% of wheat protein is ATI, and ATI could be inducing some form of innate immune response. And there are a lot of studies from studies to suggest that ATI could be a real factor leading to these symptoms, and also certainly FODMAP. So again, this question remains a good clinical question at this point of time, but we don't have an answer to this.
Before Dr. Malti starts, and I have a question to Professor Amy. What is the reason for transaminase in celiac disease? As from the delegate, one of the delegates asked, do they go into progress into chronic liver disease, or does it show it the severity of the disease?
Yeah, it's a great question related to transaminitis. So, not uncommon to see in patients with celiac disease. In fact, sometimes that's how they come to clinical attention is they have abnormal liver biochemistries. They have the whole workup for those, including viral hepatitis, other autoimmune markers. And in the end, someone checks a TTG, which they should in the workup for transaminitis, and it's positive. So again, that may not all be directly related to celiac disease in the liver. We've seen what we call celiac liver, and we see sometimes that transaminase improvement just with gluten-free diet alone. But there are many other reasons those patients may have transaminitis. One, again, we talked about a third of these patients may have elevated BMI, so they may have fatty liver unrelated to celiac disease. Again, like I mentioned, just because this is in the autoimmune category of disorders, if you look in, the transaminitis is persistent despite gluten-free diet, you really need to think about, and probably at that point we'll have already checked them for autoimmune hepatitis, because that's the most commonly associated autoimmune condition of the liver. So it'd be important to evaluate for that, because that needs to be concurrently treated and not waiting 2 years to see if the gluten-free diet alone is enough to improve the liver biochemistries. Important to also check, though, if you only see transaminitis, make sure they've had alkaline phosphatase and bilirubin checked, because like I mentioned, they're also at risk for primary biliary cholangitis. So most of these patients, I would say, because we've looked at liver histology in a very large cohort of patients here at Mayo Clinic who have celiac disease, who have had liver biopsies, most often there is some concurrent other condition of the liver that has caused any kind of progression of liver disease. And like I said, usually in the past, it was viral hepatitis, it was, metabolic associated liver disease or some other concurrent autoimmune condition. Very unlikely to be from celiac disease in and of itself alone to cause end-stage liver disease.
Okay, thank you. Professor Malati, you have a question to...
Yes, Dr. Govind, I think what is really confusing all of us is that foggy mind and tiredness is there some explanation? You gave a good algorithm for the various amylase trypsin inhibitors that might do, but where is this working? What is that foggy mind and the tiredness? Has anyone done this magnesium, vitamin D? What is it? Because now you think we can blame everyone and say you can diagnose at 10 years and start doing that, they come with a foggy mind.
Malti, I was also a little confused, and the other thing is schizophrenia also there. So I want some explanation from Dr. Govind.
I think they are great questions to which we don't have answers really. So these patients, because one is new disease, always a trend that you want to relate the symptom with certain diagnosis, and NCGS or non-celiac wheat sensitivity have been found that these patients, like their associations, this point in time, no confirmation of this. Foggy mind have been seen that those people who have the forgetfulness, they speak on the forgetfulness, and they got better once they stop wheat in them. So there's good data on that these symptoms get better, but not for schizophrenia. not for schizophrenia. But again, that is listed in the symptomatology, symptom complex of non-celiac wheat sensitivity.
You mean this more of observations which are authenticated, and these are the symptoms disappear on stopping the gluten and maybe reappearing after starting again the gluten.
Again,
That's the reason why it is so important, this one. I have one, Dr. Mohan
can I add
Prasad.
one point out here?
Yeah,
The
please.
response could be a placebo response. At the same time, this response could be a nocebo response. So placebo means people start thinking that I'm getting better, but again, there may be cause and effect relationship. So the whole science of non-celiac has to go forward in terms that what are the real value at this point of time. At this time, the symptom response may be real or maybe placebo effect.
Thank you. I have questions from the panelists and the interaction. Dr. Mohan Prasad. Dr. Mohan Prasad.
Chandru, hi. So thank you so much for inviting me. It was a great learning. It was fun learning from both Professor Ami and Professor Govind. Amazing, as Malati put it. And I had a fogging of mind even without taking gluten. So, I have a question to Professor Ami. So you were talking about the budesonide, and you said open capsule, crushed, open capsule, uncrushed, and whole capsule. Why do you have to do this? I just wanted, what is the rationale behind it?
Yeah, that's a great question. So I think when you think about how typical how typical budesonide works, right, is it is opened up and released in the distal small bowel. That's not necessarily where you need it to be effective in patients with celiac disease, which is typically a proximal small bowel disease. Patients with refractory celiac disease, though, may have disease activity throughout their small bowel. So this sort of manipulation of the budesonide can give it a more entire small bowel contact. So the first one by chewing the granules, again, those would be most easily absorbed in the upper GI tract. By opening the second capsule and swallowing those granules without chewing them, again, probably gets those to be effective a little bit more, further down in the small bowel. And then that intact capsule that's taken with dinner time, again, will treat the distal small bowel. So that's typically, if I have a patient with refractory celiac disease, that's how I will start dosing them, 9 milligrams a day in those 3 different administrations. As I start to taper down the dose, though, let's say after several months they've had great clinical response, they're starting to feel better, diarrhea is improving. If I'm going to start to taper, I typically first actually remove the entire intact capsule taken at dinner, because again, it's a more proximal disease. So I typically, do the reverse order of removing the dinner one first, then the lunch one, and then if that makes sense, just so I'm making sure to maximally treat the proximal small bowel.
Oh yeah, that rings a bell. Just like treating a eosinophilic enteritis, or even
Exactly.
the Crohn's disease of the jejunum versus the Crohn's of the ileum. I mean, that makes sense. Now I understood the whole thing. And I just wanted to add on, like sitting in South India, along with our governor, ACG Governor T.S. Chandrasekhar, I'm south of him. So we do not see much of celiac disease in South because we are rice-eating population. But what my colleagues in the United States say is that when somebody translocates to the US, even the South Indian population, on exposure to too much of wheat, they also develop symptoms of celiac disease. But what is more eye-opening is, I was thinking, I was always questioning whether this non-celiac gluten sensitivity, is it a legitimate diagnosis at all? But after listening to you and to Professor Govind, I'm very convinced. Now, probably a lot of people who do not have a classic diarrhea, but have other symptoms like fatigue or bloat or other things, we should probably start looking, and the biomarker of the AGA probably might help us in this population.
Okay, a small request to all the panelists, faculty. Quick question and brief answers. We have 25 questions to be covered. Okay, Govind.
Yeah. So again, I mean, this is a great observation. We all know that the celiac disease is less common in southern part of India, and our studies shows that. But we wanted to answer this question: that what happens to South Indians who comes to North India. And we did a study in South Indian who migrated to North India, and we looked at about 20,000 families, and we could find 1,700 subjects who agreed for participation. And we found that indeed 0.6% of them have celiac disease. So
That means epigenetics works.
no, we are not
Epigenetics
sure about it. It may be more exposed to wheat because once they go to North India, early part of life, they start getting gluten, and therefore probably no population except for Japan who may not have celiac disease, but all the population are at risk of having celiac disease. It's just a matter of time. We are becoming a wheat eating population, even say rice eating. But ask it how many South Indians don't eat puri and chapatis. You eat once in a while. So celiac is going to come. It's not about how much rice you take and how much wheat you take. It's about exposure. So we don't know how much exposure is not yet still clear. But looks like that the exposure in early part of life make you susceptible to celiac disease. So
Govind,
Okay.
can I add here?
Okay. Now we have
You
a
have done that
yeah,
study.
Uday.
Yeah. So, Govind, can I add here? You have done that study looking at the HLA and celiac disease frequency in the Northeast, Southern India, and Northern India. Now, according to your finding, are Southern Indian predisposed? Do they have HLA of celiac? That will
yes,
answer the
yes. The answer is yes. That in a subset of not whole population, we have a 23,000 subjects, but in HLA was done about 600, 200 from each center, each site. And if you look at combined DQ2 and DQ8, we're 30% all three sites, about one third of them, like rest of the world. The southern part of India, there were more DQ8 compared to DQ2. In other part of India, more DQ2 compared to DQ8. But again, one third of them do have same predisposing disease. Again, that made more to it that in our country, about one third of them don't have DQ2 and DQ8. I think we can discuss this, not in this forum, but I also
No.
to highlight that one third of them don't have DQ2 and DQ8. They have a DQ4.
Okay. You mean to say that the HLA works? That is the one responsible for this, whether it is from south to migrating to north or north people migrating south. But HLA remains there with them, so that is the reason. Now we'll come to Dr. Arvind, who has got a comment and a question. Dr. Arvind, another panelist. Dr. Arvind,
A question, is there a role for larosotide?
the role for
Larosotide acts on the tight junction.
one of you want to take up this?
I couldn't fully hear the question.
Or any newer drugs available in the market right now?
Yeah.
Role for larosotide.
Oh, liraglutide is there a role for this in the market? So I think we're going to see continue to evolve. You know, again, in my slide, if you look at the one slide later, you'll see where all of the studies are in terms of various phases. I think the one thing that's interesting is we think about any of these therapies are, and maybe, you know, continue to be widespread available in upcoming years. The thing that we have to be mindful of is I don't yet know that we're to the point where any of these therapies that are soon to be emerging will necessarily replace the gluten-free diet, at least at this point in time. Maybe future cellular and stem cell therapy will make a difference in those patients. But I think right now those therapies will be an adjunct, in my mind, to a gluten-free diet, so that if gluten is, you know, cross-contaminating or gets in the diet, it will be less injurious than having nothing. But I don't think it's going to probably replace the gluten-free diet at this point, just because the various mechanisms of action of those various therapies that are being evaluated.
So diet is the key. All these medications will be the supportive one.
Right.
Okay, Dr. Arul Prakash, you have a question and comment. Dr. Arul. Dr. Arul, unmute yourself.
Yeah, thank you, sir. Excellent topic, both of them. So I have a doubt, Dr. Govind Makaria. He said the biomarkers for NCGS, is that found in common population, those who don't have, I mean, we have found out this anti-gliadin antibodies in people who have suspicious of non-celiac gluten sensitivity. What is the proportion of people in a normal population have this antibody. Is there any information on that, sir?
Again, we don't have any information on that. The study from Italy, done by Umberto Volta, was also in patients who had NCGS, and even our patient with IBS. So we don't have data on AGA in population. But this could be a good way to do study that what is the population, how many people have AGA antibody positive? And that's a very good question. But we don't have data at this point of time.
Thank you.
But those who have really the control, the study they would have taken control, no? Where they would have done this anticoagulin antibody.
No, they don't
to
control.
check whether the increased incidence among the non-celiac gluten sensitive must have compared it. Then only they would have really come to the conclusion this antibody. Your Arul, your point is very valid. I think maybe we have to go through the entire data on that. Without which, suppose even the normal population itself is very highly positive, then will not have any meaning in the NCGS. Okay. Anyhow, both the talks is very inspiring. I like to have a comment and thing from the question from Dr. Balamurali, another panelist of ours. Then we'll go on to the second round to the moderators and panelists. Okay. The Balamurali.
Good afternoon, sir.
Bala?
That was an excellent lecture. I think you can hear me now. Hello, can you hear me?
Yeah, I heard.
I have one question. So, when to suspect that enteropathy-associated lymphoma in a patient who has been diagnosed with celiac disease? So, this question.
Professor Amy?
Yes, sir.
Yeah. So that's a great question, and it's the thing that most patients with celiac disease that's diagnosed most fear, right? Because they go to the internet, they Google celiac disease, and that's the first thing they see is the risk of lymphoma. So obviously the patients that we may see who get it, maybe those who follow a gluten-free diet strictly, but obviously if they don't follow a gluten-free diet and they continue to have that, inflammation and lymphoproliferative response in their small bowel, that is going to just obviously put them at higher risk of refractory celiac disease as well. But I also tell them as much as they can get the lymphocytosis controlled in their small bowel, that chronic inflammation controlled, obviously that decreases their risk. So I use that as a motivating factor, especially for those patients where compliance could be an issue. Again, some people may get lymphoma despite all of the compliance in the world, but I tell them if they can control the inflammatory process there, that will decrease their risk. The ones that you should suspect it though, and oftentimes, sadly, some of those patients are diagnosed with celiac disease and lymphoma concurrently because they present with pretty significant symptoms of diarrhea, weight loss, B symptoms. And so when you see a patient with celiac disease at initial diagnosis, probably particularly those who are older, like 60 or older at the time of diagnosis, who have pretty profound weight loss, you really should evaluate them for lymphoma, refractory celiac disease or lymphoma, by basically doing immunostainings, having your pathologist do markers. I would make sure probably to not stop with just duodenal biopsies in a patient I'm suspicious of lymphoma. I will get enterography imaging or other imaging of the entire small bowel to look for abnormalities there, and if needed, do push enteroscopy or deeper enteroscopy to get more distal histology if the duodenal biopsies are unimpressive. So I think more profound symptoms, but again, some of that could be at the time of diagnosis of celiac disease, so to be mindful of that.
Thank you. I think the weight loss is the key, and the refractoriness, I think that is an important another assessment. Mass lesion in the enteroclysis will help us to identify this. I think we have a question from my colleague, Dr. Gokul, who has been the organizing secretary of this meeting.
Hi, good evening, everyone. It was great listening to Professor Amy Oxendenko and Professor Govind sir. I have a question to Professor Amy. Do you think the prevalence of celiac disease is increasing worldwide? If that's so, what could be the possible reason? Is that related to more and more processing of such wheat products?
Yeah, it's a great question. And I think it's probably a multifactorial answer. It probably, we see some areas maybe with increased prevalence, others that are a bit static. But I think because of areas where we see any growth in prevalence, I think it's, like you mentioned, is it how we're processing foods and the foods that we're eating? Certainly that has a play. I think, again, when we think about things that change the intestinal permeability, I think as we see more and more infections, whether it's, and they're not even GI infections, right? Systemic infections, COVID infection, more antibiotic use and administration, all of those things are likely leading to dysbiosis or change in the permeability of our small bowel that makes people potentially more susceptible. So I think it's not one specific answer. I think it's probably related to the food we eat and how it's processed. And I think it's related to other things that likely affects our gut permeability.
Thank you.
Thank
Yeah, before another colleague of mine and who is an international ambassador for this, Dr. Vivek wants to ask some questions on.
Evening all. Excellent talks by both of you. I have one question to each of you. First one to Dr. Oxentenko. Have you had any issues with the interpretation of the pathology results when you get the biopsies? Or, we see it more common with Barrett's esophagus and low-grade dysplasia, where the pathologist is really hesitant to call it as a low-grade dysplasia. Do you have similar issues with celiac disease? Because it's a low prevalence disease, and are we missing out on a few of these diagnoses? And the question for Dr. Makaria is, in your experience, sir, with celiac disease comparing with non-celiac gluten sensitivity, does one set of population has the symptoms more severe? And, is there any long-term follow-up of patients with non-celiac gluten sensitivity to see, do they become eventually celiac patients? Is there any data on that? I will let Dr. Oxentenko go first.
Perfect. It's a great question. I think, this is why if someone comes to me for an evaluation of celiac disease or non-responsive celiac disease and the biopsies were done elsewhere, I usually have those, biopsy results, not just the report, but the slides actually sent for our pathologist to review. And I think because there's a lot of variability of what may be put in a pathology report. Some people may just put, this looks like an enteropathy without much detail. That's not as helpful to me as if it's a pathologist, a GI pathologist who details what they actually see. So often our pathologists at Mayo have a very standardized way that they will report out the small bowel biopsies. If there's concern about an enteropathy, they will give us the actual count of the intraepithelial lymphocytes, 40, 60. So a number is helpful. That tells me at least something that I can check into response to therapy. Villus atrophy, is it patchy? Is it total? Is it partial? The level of crypt hyperplasia, the inflammation. And then they will often make sure to comment on just a few of those other things that may or may not be a mimicker. They will say there's a presence of plasma cells, presence of goblet cells. So they'll give some of those additional things. Then they usually have a very standard sentence that follows. These findings can be seen most often in celiac disease, but other things that need to be considered include XYZ. So they will sometimes have that disclaimer, but again, if you've ever done, spend any time with your GI pathologist, they can look at the record, but they're seeing the slide. They don't necessarily know the detailed patient history. They may or may not have access to the serology. So they're reading what they can. And if there's any hesitancy for them to commit, it's probably just because they don't have all of that information that we have in seeing the patient. So if you get one of those biopsy results that seems non-concrete, I think calling that pathologist to say, can you give me more detail? How many lymphocytes? Do you see this? Do you see that? I think that can be very helpful in the context of clinical situation, can be a useful dialogue with the pathologist, but never hesitate to have them reread. And if you're still not sure because they were done elsewhere, get your own biopsies and have them read by a pathologist you feel confident in.
Thank you, ma'am.
Thank you so very much. I think, again, wonderful question. That non-celiac gluten sensitivity, how long the sensitivity lasts. So what are long-term data? Long-term data is not available. And shorter-term data says that a small number of patients who were diagnosed to have a non-celiac, and they can tolerate gluten later. So again, long-term data is now not available of what happens to them. But again, the context is that if somebody takes gluten, its symptom appears immediately or within hours. This is not celiac. This is non-celiac. Because celiac is a adaptive immune response, the symptoms are no day-to-day variation. Symptoms are more permanent, right? Therefore, day-to-day symptom with gluten ingestion is a non-celiac. So I have started believing that there are some patients who can have both celiac and non-celiac. And why I say so, because for those patients who have a fatty liver disease and they are taking alcohol and are diabetic, in that the fatty liver is because of two reasons: alcohol and diabetes. So the same patient, same liver, they have two pathology, two causes into same pathology. Same in, it might happen that in a small subset, I know how small or how big the subset, that they have a celiac disease, means they have a adaptive immune response to cryptoglycan peptide, and also have an innate immune response because of glycan protein or carbohydrate. So, so at this point in time, I think we have to have a long-term data on these patients. The problem is that there are no biomarkers. Your diagnosis remains in doubt, and therefore we need to have a more and data on this.
Thank you, sir.
I think all of you would agree with me that we had an excellent discussion on the both interesting topic. The final comment by Dr. Malati and Uday before we move on to the 10-minute session on the chit chat with our faculty to know more about our faculty, so that will inspire our thing. Uday, you have a final comment to make?
I think celiac disease and non-celiac are very important because they are common now in our country as well. And non-celiac is an area which, as Govind correctly highlighted, is currently evolving. As time goes, we'll learn more. Probably we are in the phase in non-celiac what we were in celiac maybe 30 years ago. So what I am saying is this is a very important area for research, and both Amy and Professor Govind has done very great justice to the topic, and the discussion was very interesting and thought-provoking.
Thank you, Uday. Malati?
Yeah, thank you, Dr. Amy and Dr. Bakaria. It was really excellent, and the panel discussion added to the icing on the cake. So it was very nice. So I was thinking, in South we are not seeing much, and I would like to list the same wavelength to go on in South India. So if exclusive breastfeeding till 6 months, and if we don't introduce wheat at least till the 1 year, especially for families where celiac is high or we suspect, would that be a good way to keep it down? Because I think that was one thing in South India. We introduce rice as our cereal when we start solids. We don't introduce wheat for the general South Indians. So that was probably because I was very interested when everyone used to talk on celiac disease when we came to the north, and we didn't have even one case. So that's why I published that paper. Is celiac disease still uncommon in Tamilians? And still we don't see. It is only those who have come from north and settled here for a long time. So I think this should be a lesson. Exclusive breast milk till 6 months, and then probably introduce rice as the weaning food.
Thank you, Dr. Malati. Now we will go on to the chit chat session. One word answer from the faculty, that is from the speaker and moderator and panelists. What is your mantra for work-life balance? Professor Amy.
One word answer, I would say for me, is running.
What is that?
Running.
Okay,
I got my 6-mile run in this morning.
Don't give time to think about that. Okay,
So,
Dr. Govind.
A good spouse. Good spouse. Good wife.
Good spouse. That you have to choose.
Understanding
no?
spouse.
Okay, now Malti, what is your idea about work-life balance?
I think it's my passion for work, and also I have this so I can balance both. You must have a passion for work.
No, the question is mantra for work-life balance. Now you are balancing that, I agree. What is the mantra?
Mantra.
A lot of youngsters, as many as 700 people are watching all over the world.
Yes.
From all over the world.
Mantra,
so
you should be able to, you should know what you have to do for both. You cannot leave one and then take the other. Balance,
you
and a good family support. That is, I think, a very important.
Your answer is running one is good spouse, one is the family support. Uday, what is your work-life balance?
Enjoy what you do, that is one. Second is concentrate on what you do at that time and don't think about other thing at that time. And third is, yes, the family support.
Okay, Mohan Prasad. Mohan, okay, he's already balancing there with the Family, I think. Okay. Now, now, what is the non-medical book I just recently read, Dr. Amy? Non-medical book.
Non-medical book. Wow, I read several books a week, so I'm trying to think of which one I just
One
finished.
which would really inspire us and the delegates. Non-medical
Let me
book.
think. Come back to me. Let me think of which one I'll pick.
Okay. While you are thinking, can I ask Dr. Govind?
No.
Okay. Dr. Amy, you came out something.
Yeah, so right now it's an audiobook that I'm listening to. It's called Never Finished. It's by David Goggins, and it's on how your mind and your body have to both be aligned to achieve great things.
Okay. What about Govind?
No books, but I listen to TED Talks, but no books.
Okay, TED Talks. What about Malti?
I'm reading a book called Purpose Driven Life by Rick Warren.
Okay, very good. Uday, what is your book?
Look at this book. Actually, I'm fond of Bengali literature. I write poems, and this is the book of Nirendranath Chakraborty. Great book. I was reading that book.
Is the question leaked out to you? You are keeping the book also ready?
No, you see on the back of my desk, all the books are visible.
Okay.
All blurred, but they are visible.
Okay, now the question is, what is the famous quotation you like, Dr. Amy? Dr. Govind, Uday, Gosal, and the Malati. What is the famous quotation which you really adore or like or you follow it? These
Famous
are the questions, not quote. Now, this is more difficult than celiac disease appears.
I think and I'm paraphrasing. This is a paraphrasing of a quote, but it's not. People don't remember what you say. People remember how you made them feel.
Okay, right. Govind, what is the famous quotation you like?
So I believe in good attitude matters.
Okay, right. Go, Uday.
Yeah, I just recently posted that in the Facebook page.
You are always ready, Uday. Book is ready and Facebook is ready.
Look at this. A bird is not afraid of falling because the branch of tree on which he is sitting is broken, because he believes on his wings and not on the branch of the tree. He believes on his wings and not on the branch of the tree.
Okay. Malti, what is your quote?
Mine, yesterday
Don't
is...
tell me white quote.
Yesterday is history, tomorrow is mystery. So only today we have, and that is why it is called present. It's a gift.
Okay, right. What about Dr. Gokul? What is your quote? So you should always be prepared for unprepared when you are unprepared only. Okay, who is your favorite Hollywood actor or actress, Dr. Amy?
You keep calling me on me first. I need more time to think about these things.
You have never watched a Hollywood movie recently, I think.
I do. You know who I really like is Liam Neeson. He is in a lot of action movies. So Liam Neeson is who I might be one of my top.
Okay, I like it. And Dr. Govind?
I would talk about Bollywood. So this is
you tell from Bollywood. Okay.
Amir Khan.
Amir Khan. Okay, Malati?
Oh, I'm an old timer, so I think school days Hollywood. Clint Eastwood and all were our favorites. Clint Eastwood.
Who is that?
Clint Eastwood was that time.
Clint Eastwood. You like the Western movies, huh?
Yes.
Okay, right. Uday? Apart
Yeah,
from Bengali.
old is always gold. I like Uttam Kumar and Suchitra Sen.
Again, you are coming to the Bengal only, no?
That's what I'm back.
Who is the actor you like? Come. Vivek is a gastroenterologist in Augusta, Georgia. He is my son.
My favorite Hollywood actor is Tom Cruise because till this date, he does his own stunts. So I really appreciate that.
What about in Bollywood?
In Bollywood, Amitabh Bachchan.
Okay. In Tamil movie?
Tamil movie, Kamal Hassan.
Okay, right. You are through now. Okay, now what is the, how will you cool down when you are, how do you de-stress, Dr. Amy? When you are really stressful, how will you cool down? One word answer.
Well, I think that actually is the first question you asked about work-life balance. One word answer. I said running. That's probably my best
Again running,
way.
huh?
I can run, and when the more stressed I am, the faster I will go.
Okay, what about you, Govind? How do you de-stress yourself?
Just
You
go
sit
and
and huh?
relax, have music.
Running and you are huh?
No, music.
Music. That is very good. Music is a great thing. Malti, how do you de-stress? I never seen you stress.
Music.
Music. Then Uday, again,
Music.
Poetry.
poetry. Hey, okay, right there. Now, what is the path for a clinician to get Nobel Prize in medicine? I mean, naturally in medicine. What is the path?
This you should ask Bere Marshall next time. This question should be
Keep the question for next time.
Yeah, that's right.
Okay, right. We'll ask Barry Marshall next time. All of you join. And what is the future of gastroenterology from your perspective? After 30 years, we're all meeting for such a webinar or meeting. What will be the future? Starting from Dr. Amy.
Yeah, I mean, I think we're already starting to see the future already with artificial intelligence and all of the tools that will help us hopefully prevent disease before they even occur, prevent cancers before they occur. I think we're already embarking on that. So I think 10 years from now, it will be interesting to see how we see just the prevalence of disease and cancers change over time because of those advanced diagnostics. So that'll be exciting.
Okay. What about the Govind? Quick answer. Artificial intelligence, genetic diseases.
Something we don't even see today. Something we don't even understand today.
That's what future is.
So the future will be something you keep evolving. So something we can't imagine now will be the future.
Something unimaginable will come into the future.
Absolutely.
Malti, yours?
Yeah. I think AI will take over and the individual will be able to make their diagnosis. And gene therapy, I think, will come a long way. And we will be able to do something better for them.
I think genetic diseases, gene therapy, AI, robotic surgery, minimal invasive procedures, or the multi-system problem will be there, lifestyle-related diseases, all these things will be in the future, and people want quick remedy, and they don't want to wait. Sometimes they have less patience, all these things. Now, last question, what is the turning point in your career? Dr. Amy. Quick.
I think the turning point in my career was the day I decided to change from being a math major to a pre-med major. Otherwise, I'd be teaching college math right now if I hadn't made that change.
Govind? Joining AIMS is a turning point?
No, a patient with celiac disease.
The moment, the time you started in celiac disease, that's I was expecting that. Malti, your turning point?
Turning point, I think when I applied for cardiology, they said, no, take gastro, and I came into gastroenterology. Otherwise, I would have become a cardiologist.
That's the turning point. Are you repenting or happy?
No, I'm not repenting. After being with you and working with you, how to repent?
Oh, that's very good. I got my day done. And Uday, what is that your turning point?
Turning point, I was in a remote village, suddenly got selected into medical school. That was one turning point in my childhood. And the second turning point was getting into motility.
Okay, only one turning point will do for this meeting. Okay, thank you. And people ask me, what is the famous quotation? Do you like? They asked me, but unfortunately did not ask me. But I want to tell you one quotation which I like recently now. Is the man with no purpose will derive pleasure, will divert himself with the pleasure. So all of us we have a purpose here. We have met here and we discussed about celiac disease and non-celiac disease. Those who are non-believers have become believers of non-celiac disease, and those who want to know more about celiac disease, we listened to Dr. Amy and Dr. Govind, and we had a terrific moderation by Dr. Uday and Malati, and we had a great panelist, Dr. Mohan Prasad, and Dr. Arvind, and Dr. Arul Prakash, and Dr. Balamurali, and our webinar ambassadors who have really made the program so successful. As of now, we have 706 people from all over the world who have logged in, and we enjoyed. And I thank my colleagues also, and I thank my academy partners, Microlab, and my team who have really made it. And this is the 12 plus and 20th webinar we have been doing it. And please join us for the next webinar. This is going to be by Professor Marshall. He is also going to discuss about how he discovered H. pylori, what are the difficulties he had, how his first paper was denied, publication was denied, how people became non-believer of H. pylori, became believer of H. pylori, how when there is no study available, no ethical clearance was available, how he consumed the H. pylori himself, and how he developed the symptoms, how he established the diagnosis, and finally how he got the Nobel Prize. All these things we're going to discuss. Thank you very much for this wonderful evening. We all of us spend a great time in learning more about celiac disease. My special thanks to Dr. Amy and Dr. Govind and Dr. Malati and Dr. Uday and my panel. Thank you very much.
Thank you. Thank
Sign
you.
off.
Thank you.
Bye-bye.
Bye-bye.
I hope, Dr. Amy, you enjoyed it.
Oh, it was
the
great.
webinar.
It was fantastic. I'm just seeing all the questions in the chat. I don't know if we were supposed to be answering those, but I think we addressed
Yeah,
most of those throughout the talk.
you can.
Good. No, it was fantastic. Thank you for having me, and great discussion.
And please convey my regards to Dr. Patrick Kamath.
I
He was
will.
my
I will.
mentor
Will we see you at ACG in Philadelphia?
Yeah, see you there. I
See
think
you
you
there.
are taking
All right.
over.
Yes.
Huh?
Yes. We'll see
You
you
are
there.
taking over the president, and I have 2
Yes.
more years to go as the governor. So we'll continue this. Maybe next year you will be inaugurating our webinar.
There you go. There you go. Would love
Okay.
to. All right. Take care. Bye-bye.
Okay, thank you.
Uh,
Dr. Aravind, thank you.
Yes, sir. Thank you very much, sir. Great webinar.
Sir, should I
You can
end
stop
the event?
recording.
Yeah.
Yeah.
I'm just
You can
ending the
stop
event
recording.
then.
Thank you, sir. Bye, sir.
Let's wait for
Arul,
some more time.
thank you. Mohan, thank you. And Bala, thank you.